Right, so it's, the problem is coexisting DME and ERM, so solution one is treat the DME first, solution two is treat the ERM first. And I'm sort of for the first solution, I'll show you why. Before we move on to why and make some points, is we need to decide what type of cases are we talking about. So let me just show you an example. This is definitely a diabetic patient which shows lots of leakage. And I'm sure you would expect that the OCT would show lots of edema, but that's how his macula looks. So there's no doubt that there is a macular hole in diabetic patient with leakage. And of course, there's no doubt that I think we should treat that patient by offering surgery, and that's what I did. And the surgery is closed, and the vision has slightly improved. But look at his left eye. Again, lots of, or some leakage there on a late stage, and it's definitely vitreomacular traction. So here's a diabetic patient which has a severe vitreomacular traction with an epiretinal membrane. And I'm sure you would agree this is a surgical case, so there's no debate on that. If this is what we're talking about, then yes, there's no debate. Surgery is what's needed. We offer the surgery to the patient. The patient just wanted to have the cataract removed. I did that. And we're still offering the chance to have surgery. The vision slightly improved. But look at that other patient here. Here you do have a diabetic with mild epiretinal membrane and a edema there, and we offered a few injections, 4 injections of Avastin, and it has improved, and the vision has also improved. And the same happened with this patient, and if one might argue that the previous patient was a very thin epiretinal membrane, here is a bit more thicker. And again, we offered injections, and the patient has indeed improved anatomically and functionally. And I think these are the types of patients we should be arguing about or debating on. So if you're about to give a conventional treatment, actually treat the DME first, what you're doing basically is you're doing what is a worldwide approved treatment. And this doesn't mean that if this treatment fails, you cannot move on and do a vitrectomy later. This is exactly what I'm talking about. Whereas what Lyndon is going to try and convince you about is that we have to move on straight onto vitrectomy. In other words, patients like the ones which I've just shown you, the second one, the third one, you have to just start with the vitrectomy and remove the epiretinal membrane anyway. If this is the case, you have to convince your patient about the results, the benefit of it versus the risk, the adverse events, and the cost. In other words, you have to convince your patient and yourself as a surgeon that doing the surgery is absolutely mandatory, and you got the data and the experience, the real-life experience, to support that. And I'll try to convince you that this is not the case. So we need evidence. Is there any evidence there? First of all, is there any evidence to sort of support exactly straight this direct question? Would vitrectomy on DME, when there is an ERM or an abnormality of the vitreomacular interface, do any better on those patients? And I managed to find a nice meta-analysis, and these are all prospective trials. I mean, they're good quality, although they are fairly small numbers. And all of it, apart from one study, they looked at cases where there were no tractional detachment on DME patients. Only one study had a few vitreomacular traction cases. And here, unfortunately, they showed that vitrectomy doesn't do any good. And this is another review study, and they reviewed everything what is left to be reviewed. Most of the studies were very, very small and very, they were not controlled, basically, so they didn't compare vitrectomy with the anti-VEGF treatment. And what they showed, that it may be some anatomical improvement, but the functional improvement is very ambiguous. And perhaps the ones who did show some improvements are the ones who did have an ERM or a vitreomacular interface abnormality, but as I said, very small numbers. So what about evidence on another subject? Let's look at it from another point of view. Would the existence of an ERM or an abnormality on the interface affect the effectiveness of the anti-VEGF? So in theory, if there is an ERM, this would sort of be a barrier in terms of allowing or preventing the anti-VEGF to penetrate through the retina, as well as applying tractional forces and affecting the blood-retinal barrier. And in fact, there is some in vitro data showing this. So in other words, there is a model of an epiretinal membrane which showed that perhaps this is true. But in real life, although there are some sporadic publications coming up, the results are very ambiguous in terms of anatomical and mostly functional. And most of them are non-randomized, and they are mostly retrospective. And let me just show you some examples. Here is one study which did show some improvement when there is no ERM, but this is only anatomical improvement, so no functional improvement. They didn't mention anything about it. Perhaps the only study, which I'm sure Lynn is going to talk about, that did show some functional improvement in terms of how effective the anti-VEGFs are on those cases, is the one which I'm just showing you here by Wong. And then again, if you just look at it carefully, the follow-up is very, very short, less than a year, and only 4 injections given. So we don't know what happened or what would have happened if they gave more injections to the ones that did have ERM. On the other hand, there are, as I said, ambiguous results. There are other studies showing exactly the contrary, the opposite. So the ones who did have a DME and an ERM did functionally better than the other ones. Very ambiguous results. So overall, the evidence is very, very poor. It's very weak. And as far as my understanding goes, the benefit of doing a vitrectomy on DME when there is an ERM, well, it's only theoretical and it's not proven. What about adverse events? If you're about to do a vitrectomy, you need to think about it. And in particular, the question is a vitrectomy in diabetic patients exactly the same as a normal vitrectomy? The answer is probably not. And that's for various different reasons. The vitrectomy on diabetic patients is more challenging because you've got stronger vitreomacular adhesions, you've got a thicker ILM, you may be inducing what we call a floor effect, which means atrophy of the retina if you remove the ILM. And the ERM itself, the membrane itself, is different. It's evidence about it. So in other words, the idiopathic ERMs are more scarred, or they may tend to cause more scarring than the diabetic ones, which means there's no probably any good evidence to remove the diabetic ones. So what about adverse events in general? So we know about cataracts. Perhaps this is not important, but if you think that we're doing a cataract, which we're inducing with a vitrectomy, on a diabetic patient, this may be introducing an extra inflammatory element on the diabetic edema. So in other words, cause an Ewing gas type of edema on a diabetic macular edema. So this is not very good news. And of course, for the reasons which I just mentioned, you may end up with more retinal detachments because it is a more complex procedure. And finally, well, endophthalmitis is very rare, but you may get it. But if you don't do a vitrectomy, it's unlikely that you're imposing an extra factor. And of course, there is evidence, although rather poor, but if you do a vitrectomy, you may be reducing the effectiveness of the anti-VEGF because they wash out much earlier and easier. What about cost? Of course, you understand that you are suggesting to the patient that you're doing a vitrectomy, and this would increase the cost. And Lyndon might argue that yes, but this may reduce the need for further injections, but this is not proven in the literature. So the patient is likely to still more injections plus having the vitrectomy, and this will increase the costs. So remember my first slide, well, on my first few slides. Have we managed to answer those questions? Do straight move on to vitrectomy? And the answer is no. No results, no benefits versus risk evidence, no adverse events, more adverse events, and the cost is definitely higher. On the other hand, if we just follow the normal pathway of just doing the injections, we're definitely offering a reasonable chance of the disease to be stabilized. We are avoiding costly and unnecessary surgery. We are avoiding the extra risk factor, which I just shown you, and it will allow the patient the chance to mentally be prepared to have the surgery later on if needed. In other words, if our treatment fails. So for all those reasons, I think I have already convinced you that we should treat the DME as you just voted, actually. Thank you very much.